Welcome to the Let's Talk series. The Let's Talk series is a 30-minute video discussion between myself, Dr. Becca, Dr. Amanda, and a local practitioner, in this case, a Dallas-Fort Worth special practitioner who understands pelvic health on topics pertaining to women's health and wellness. This series was created to help women navigate their pelvic health wherever they are on the path of womanhood, to advocate, navigate, and collaborate together with a holistic team of allies. Pelvic health healing is multidimensional, and the best outcomes occur with a team-based approach. So we invite you to tune into our monthly series to learn more about your pelvic health and engage with our community and worldwide.
Yeah, now we're like nationwide.
So today's speaker is Dr. Yeni Abraham. As I said, Dr. Yeni is actually a pelvic floor physical therapist or pelvic health physical therapist out in the Dallas-Fort Worth area. Dr. Amanda and I have both had the pleasure of taking some of Dr. Yeni's courses in the past. So that's kind of how we were introduced to her, and just really thought that she had a lot to offer to women's health and pelvic health, and how we can really be advocates for people throughout different fertility journeys. So Dr. Yeni, she's a vivacious and forward-thinking physical therapist based in the Dallas-Fort Worth area. She began her practice Triggered pelvic physical therapy in 2019 from a place of purpose to address the fertility concerns, pelvic pain, and pregnancy-related conditions that women struggle with. She's also a mentor, teacher, and practices using gyno-visceral manipulation techniques to treat and manage female mechanical infertility. Her use of these skills in private practice has addressed hormonal issues, ovulatory concerns, numerous reproductive diagnoses that impact fertility. So that's what today's topic is going to be on, is how pelvic health practitioners can be advocates and collaborate with people through these different journeys. She's a formidable woman and hails as a proud first-generation Nigerian. She is a fertility warrior herself, who is now a mother after a battle with infertility. She's happily married, passionate about growing her practice and mentoring young women, and aiming to provide expert level care. So she truly is a pioneer in the world of pelvic health when it comes to fertility. So thank you so much, Dr. Yeni, for coming on and talking with us today.
Oh, it's an honor. That bio, God bless it. It sets it up for me, but sincerely, it's an honor. I'm so happy to chat with you guys about this topic today.
Absolutely.
Yeah. So, tell us kind of how you got into the fertility world, and kind of, help our listeners kind of understand, kind of the full scope of that.
Mm-hmm. Yeah, so I think whenever folks think about physical therapists, occupational therapists, we are very much the rehab, geniuses. We're the folks that are leading rehab, what rehabilitation looks like. And so I would say that my budding interest in all things women's health really started early on in my journey. I was in PT school. I was one of those in the class that was always attending all the student conferences. I really wanted to sit under a mentor. I was hungry for information. And so early on, I just knew pelvic health was going to be the track that I would go in. And so about the first year when I started working, I started seeing folks that would have really complex conditions. So they'd come to me for like an SI joint issue. Of course, at that time, everyone thinks that pelvic health had to do more with an ortho issue, right? Then there would be a couple of folks that had bladder problems, even erectile dysfunction, because I was treating a mixed population at that time. And, I kept stumbling across folks that would come to me for dyspareunia or vaginismus, who also happen to have really bad cycles, like really painful, cycles, who also had a lot of disturbances with their hormones. And then occasionally they'll kind of slip in, yeah, we've been trying to conceive for a while. And so I just decided to kind of like, just start getting hungry about the education piece there while I was treating them. And then, you treat them with these internal techniques like we all do in pelvic health, and some of the more wellness practices. And then they not only would they be able to resolve their pelvic health conditions, but every so often I'd see cycles get improved. I'd also see patients go on to conceive. And of course, we're talking about like raw, early baby Dr. Yanni, right? I didn't know anything, and I didn't really know at the time that much of what I was doing could really have a true impact on this patient's reproductive health. So I decided to kind of go and look for some courses at that time to help me. And of course, there was nothing out there at that time in pelvic health. I think I was doing all like my Herman and Wallace classes at that time as well, but there was nothing out there. So I had to go to the osteopathic world. I had to go to the hormonal world, the naturopathic medicine world to really find information. And so that's kind of how I stumbled upon it. And I at the time had been struggling with PCOS. I'd never had regular cycles. I mean, the only thing that could manage my cycles at that time was just really clean eating. I mean, I was pretty much eating paleo. I had to work out, a certain number of days a week, but I couldn't work out too much, right? Because of my cortisol levels. And so I was already managing my personal health at that time and struggling with cycles. And I wasn't trying to conceive at the time, but I just knew, I was like, I wonder if I could just really get a hold of this, I think that I can really help my patients. So there was just a lot of informality, I would say, initially. And then this sounds really weird, but I took kind of an abrupt break and I went into acute care. And that's where it really gets good.
Yeah.
Plot twist.
Right.
Plot twist, exactly. Because at the time, a lot of people don't even, I guess I speak about this sometimes, but my acute care years were the game changer for me, medically speaking, because I had the opportunity. I was initially at a level 4 hospital, and then they gave me a chance to start floating around to the multiple hospitals in our area. So I went to trauma level 1 hospitals, major hospitals, working with complexities. And they'd always, of course, as soon as your manager finds out that you're interested in, women's health, they're like, oh, the random OB patient that needs support, or there's like a 12-year-old girl, on the peds unit that has painful periods. All of a sudden they need the physical therapist, so I got to really learn how to work with an interdisciplinary team, read labs. I was spoiled because I had access to all these type of providers that I could ask questions. Okay, with this imaging comes in, what does this mean? And I think for me, I've always been a very curious person, and I'm very vocal about my curiosity. And I think that's always been something that even till today has always helped me stay as a lifelong learner, right? Because I will lean into what I don't know and give myself the opportunity to learn. And so I kind of just lived in a place of humility those years and just try to absorb as much information as possible. And then I said, okay, what are we going to do with this? Because I was, of course, already getting bored a couple of years in acute, like I need to go back to pelvic health. This is not it.
There was a calling, like, come back.
Yeah, come on back, And so I was like, okay, I had an opportunity at the time to go back under some mentorship to a great public health provider in the area, while I still kept a couple of hours, in the acute world. So I said, why not? And so I took that and started learning and applying some of those principles that I learned as to the best that I could. Because obviously, when you're working in a more traditional environment, a lot of that is not embraced, right? They're not really wanting to hear the holistic piece. You've got a urologist prescribing this medication, and they're just kind of wanting the outcome of you resolving these bladder issues. They're not really wanting to hear that you're also caring about what the uterus is doing, right? And so that was kind of what piqued my interest to say, you know what, Yeni, if you're going to be able to truly treat the whole person and help to accomplish some of these goals, you got to start your own practice, girl. You got to figure out a way to, launch out on your own. And that's what I did. So yeah, that's kind of the oversight there.
That's what I did. I have a similar story. I may not have gone into acute care. I have just survived acute care in my clinical experience. I'll tell you that. But similar of like going through my own menstrual health stuff, always being curious. And I think that that's really where, as we develop in our practice of wherever you are as a pelvic therapist or even an orthotherapist, thinking of going into pelvic health, that, you can learn so much from your own story, but then listening to the stories of others and just being humble in that moment, like you said, of I'm just taking it all in. But there is something when I remember that same feeling of like having all this information, and I just feel like every night I'd carry it all home and I'm like, okay, now what do I do with all this? Like, what do I do with all this in South Jersey? And there was nobody around that was doing out of corporate pelvic health, and it wasn't
Yeah.
being done in a way that was serving people truly. And then that's when I opened
100%.
my practice too. So
Yeah. I mean,
totally.
I had a notebook at the time. I have it in my office, and like sometimes it's good to just kind of see where you started. I had a
Yep.
notebook where I jotted a lot of the conditions I would see down, you know. So I would jot down whenever I see someone come in with like a high risk pregnancy, or someone who currently is going through IVF, ovarian hyperstimulation syndrome. You know, maybe
Right.
they're being treated acutely for that, right? So I jot down all these conditions. I'd go home and research it. I'd go see, okay, is there a course out there I could take? Is there something that I can learn? Are there books that I could read? And that's just kind of how I started piecemealing it. But I think that, like you said, I think some of the best providers out there really come from stories that are birth and purpose, where you just know, I got to get out there and serve this population, not just because of what I've gone through, but because there's something missing.
There's something missing. Exactly.
Well, and if you're going through any sort of, health, whatever health,
Right.
it's like you're seeing this person at this place, this person at this place, this person at this place.
So
And that's one of the things that I really enjoyed about like your course, Dr. Yanni, was kind of taking like, okay, this is like the medical side, this is like the IVF or IUI side, and then this is how, so to have, and I know that's something that like, we really strive is to have someone who can just kind of like be the champion and the advocate and like support these people as they're going through these journeys, because it's extremely overwhelming. And you feel like it's like, okay, I see this person for this for this, this for this. And it's like, but who is like making sure that like all of that is all working
and
together?
at least being embodied in some way. So,
exactly. And I think that's why, as pelvic floor therapists, we're in a unique position, because we do understand what rehab is. We do also understand what it looks like by working through the life cycle of someone who maybe has a more goal-oriented mission, right? I think, I really wish that, when I was in PT school, I remember it had to have been like a couple of years ago, I was mentoring someone. I was like, are they really still only teaching you guys ortho and neuro? Like, that's it? Or just, is there still such an emphasis on ortho? Neuro is still very important for what we do, but it just felt like almost as if like we're just such a uniquely positioned. A lot of us have, we have, I would say, reputational clout in the fact that people respect what we do in the rehab space. So I think where we are missing is there's so many medical providers who just have such a short sight of what our scope looks like, right? And so this is why platforms like this are so crucial, because you can have the recipient, the consumer, the patient be the one to kind of lead that conversation with their provider. Like, hey, could you just send me to a pelvic health therapist? I'm trying to conceive, or I'm having pain with my cycles. They're like, they can do that, right? And then being able to kind of like trust the process and send that patient our way, and kind of notice that we are that joining point, that point where we can understand things both holistically, the whole person, right, as well as medically.
Right.
Yeah,
absolutely.
Yeah. And how all of that interacts.
Yeah.
Multiple different systems, mind, body, spirit, how all that kind of comes to be.
Together.
So yeah,
Exactly.
We're definitely, I'm humbled every day by, working with our clients and our patients. And, again, so grateful that you took those steps to be like, all right, this isn't out there. Well, I'm going to seek it out myself and then take that knowledge and share it to the world. So as far as like pelvic floor, like physical therapy with someone who's going through a fertility journey, because there's multiple different, reasons why someone might be struggling with fertility. What types of things do you focus on in your work or your practice that can help people through those journeys towards getting pregnant and staying pregnant and then having a healthy baby?
Yeah. So thanks for using my correct definition, right? Because for me, the goal is never just to get you pregnant, but to keep you pregnant, right?
Yeah.
And have a live baby. So thanks for saying that. So I mean, in my practice, oh goodness, it is like, I mean, it ranges. You got folks that come in and they've never done anything before. Maybe the thought just came to mind, there and their spouse know that, it's time for us to start trying. We're kind of looking at options, and we don't really want to do anything that's so invasive. So I've got folks that don't necessarily have a true condition, right? But they have a hunch that it might be a bit challenging. And so sometimes I'm exploring that hunch with them, sending them even to a nutritionist, naturopathic doctor, making sure that they've at least got some labs, maybe even if they've got a good relationship with their OB, getting their OB involved and saying, hey, let's at least get a baseline assessment of what's going on with this patient and see where we can support them along their journey. And then onto the opposite side, I am supporting folks who are going through IVF, right? Who truly have gone through the gamut of trying things on their own and are now at the stop where I've got to do the most kind of reproductive invasive treatment right now to support me to meet these fertility goals. And typically, I mean, I've had folks that have had failed cycles, and the reason they're coming to me is because they're like, I just don't want to repeat the same process again and get that same outcome. Like, I just want to give my chance of body to do something different. So in this population, sometimes we're exploring the fact that maybe there are previous scar tissue issues, right, that we're having to really, work through. So I've had, and this is something that I see often is, you've got previous athletes that have sustained all sorts of pelvic injuries, playing more aggressively, guarding, and they don't even know they've got pockets of scar tissue that are near like their pubic space that is impacting. They've got a shifted SI. And, the body keeps score. Like you just got to give the body a chance to do that detailed healing, right? So I've got folks that kind of come in for that. And then I have patients that truly know, like, I have problems. I've never had a regular cycle before. I've had, endometriosis, and I've had multiple surgeries for that. Or a big thing that I'm seeing right now, and I finally decided to do coursework about it, was fibroids. That's huge.
Yeah.
It's like, what is it? The statistic that says at least 1 in 5 women in their lifetime will have fibroids. It's pretty massive. And then of course, in the African-American population, it's like 80% of African-American women in their lifetime will have fibroids. And so in that population, you've got folks that have had multiple myomectomies, some of them closed myomectomies, some of them open myomectomies, and they just had never healed, right? And so they're, also, we're seeing folks now with advanced maternal age, right? Those folks that are on like 38, 39, and it's clear to them that, I may have frozen my eggs prior to, or I have never frozen eggs, and I have to go through the cycles to get my eggs frozen. So it really varies. But I would say ultimately, irregardless of where patients are at, my goal is to always kind of meet them at the point of their fragility, right? So what are the major drawbacks? Like, what have you not been getting when you've gone to other providers? What are some of the things that you've been missing? So I would say that my evaluations are incredibly investigative.
Yeah.
And then I'm also looking that if there's other interdisciplinary involvement, also getting them on board and communicating to them kind of what I can do. Right. So for the most part, I know most of the reproductive endocrinologists in the area that treat most of our patients. And so that sometimes looks like an email or a phone call away, right? Or sometimes our patient just feels more confident that they would like me to translate communication through them or have us fax over information. And sometimes, honestly, providers are just too busy. Do what you got to do. Treat my patient. I trust what you're doing, right? And so sometimes that's what that looks like. I don't need to police you, just do what you can do for them. And if there's anything that comes up that you're not sure of, let me know, right? And then like more recently, I had a situation where I had a patient who was going through, this would be her 3rd cycle of IVF, and whose provider previously had said, don't let anyone touch you while you're going through these cycles, right? And so she had this huge fear of coming to see us because she was under the impression that anything from exercise, eating, to being touched, getting a massage, any involvement was going to impact her outcomes, right? And so I had to kind of instill that confidence in her and kind of give her some of the language to advocate for herself. She went back to her provider, and guess who sent her back to us? The same provider, right? And so, and really the fear is just not understanding what we can do, because again, they're thinking, what is a physical therapist going to do to help my patient? But when I'm telling them that, hey, we're doing visceral work, right? We're helping to improve the way that these organs are behaving, the way that they're receiving blood flow, the way that we're helping to decongest the vessels. They're like, oh, this is great. Cool.
Right.
Yeah. The only thing we could both agree on is we're just not going to treat them right before, like a couple of days prior to getting transferred, right? And afterwards, but as long as they're like, oh, go ahead and do it. Like, it can't hurt them. If anything, it can help them. So yeah.
So I guess like for pelvic therapists interested in getting into this, the thought, and Rebecca and I, it is for a few days before an IVF transfer, and then even after, and then we wait that 2-week waiting period, right?
So not even that. So typically when it comes to IVF and specifically, so the way that I set it up is that we treat up until 48 hours prior to the transfer, and we leave them alone until we're getting either a positive pregnancy test or a negative, right? So if we get a positive pregnancy, then we don't touch them till week 10. And that's because that's when the placenta takes over, is at week
Gotcha.
10. And they typically at that time graduate from their fertility clinics and they're going to their OBs or their high risk specialists at that time. Right. And so, but when it comes to retrieving, because the retrieving is really where the work is for us, is because whenever they're doing those retrieval cycles, they're having to facilitate follicular growth. They're looking at, trying to get the best outcome, making sure that the body's responding well to some of the medication, the menopause, all the medications that they're taking during the full gamut of their retrieval cycles. And that's when the ovaries are really working hard, right, to be able to develop as many follicles. So we're wanting to mobilize the ovaries. We're wanting to stimulate as much action as possible. And then the idea is after they retrieve, we're just kind of providing a bit of recovery, because typically they're incredibly inflamed, very bloated, they feel lethargic. Patients kind of complain, not realizing how sore they were going to feel afterwards. There's a term out there, I can't think of it right now, but a lot of people feel kind of like a hormonal crash after the retrieval, because obviously you're taking these high level medications for some folks, they need even up to 2.5 to 3 weeks prior to that retrieval. And then they go and get it done or get the retrieval and their body just kind of like crashes, right? So helping them to recover can really be, and that's where we engage the lymphatic system, right? And we're really trying to help to make sure that uptake is efficient so that their bodies feel much more stable, because some folks are not waiting very long before they go to do a transfer, right? Obviously the evidence tells us that majority of patients are always going to do better when they're getting a frozen transfer versus a fresh transfer. But even with that, sometimes that looks like a 1 or 2 month turnaround, right? Especially if they're not going to get any specific genetic testing. So it really just varies based off of the patient's goal. But the IVF population is a very special population because everything is incredibly tailored, timed, specific, protocoled, monitored. And so those patients, I feel like we see them so consistently during a duration of time. And then we've got the patients that are not doing that. I have had folks for religious reasons that won't do it. I've had folks that, for personal beliefs. And then sometimes at the end of the day, it's just finances. Like they cannot fathom investing that level of, finances to do that. And so then we're working through some other options with them and at least helping them to be able to give the body the best chance to be able to conceive.
Yeah. Well, and I love that there's multiple layers to like the work that you're doing, right? Like there's the physical component of like, okay, if there are adhesions or, things are, not sliding and gliding and moving and sitting in places that we want them to be. If there's inflammation, like how can we, with some of the hands-on work that we're doing, kind of manage that? But then also from like a mental, emotional kind of standpoint and from a nervous system standpoint, how a lot of the stuff that we can be doing can really be helping communicate with the nervous system and kind of bringing that down. Because if going through a fertility journey is stressful, it's extremely emotional, and that can create a lot of just blockages and inflammation and overall challenges with that. So, and a lot of the hands-on work that we can do can help communicate with that nervous system. To get their body in more of like a steady state, because how involved like your brain even is in like the hormonal components from the hypothalamus to the anterior pituitary, like all of that, it starts at the top and then trickles down. So I think besides just like the physical standpoint, there's a lot that we can kind of do that impacts, what's that like where you got to look like, don't look downstream, you got to look upstream or whatever. I don't know. That's like a thing of like looking downstream versus
I know that one. Exactly.
I forget what the saying.
I like
I'm not
that
saying
now.
it right, but I feel like that was a lot of what I was able to kind of take from your course too, and then just understanding more of the language behind it.
Because if you haven't gone through it personally, you're like, what's an IUI? What's an IVF? You're injecting how many things into your butt at one time? And it's and then you go to do a glute skin roll and somebody's oh, my butt is so tender there. Can you not do that? And if you don't know that, like, oh yeah, that was from like the oil progesterone that they've been doing for like weeks on end.
Yeah.
And I think too, for people, so personally, I have been through my own fertility journey of things, and being able to feel what all those things feel
Oof,
like
yeah.
is like, whew, that's one thing in itself. But then there are other people who aren't in their bodies maybe as much, or who don't recognize that, oh yeah, this like weird sensation with arousal after
Mhm.
having a transfer, or after having a transfer that didn't produce a babe at that point and they're waiting for the next one, that difficulty with arousal or pain with arousal, or all of a sudden this urgency frequency with their bladder, that's stuff that we can impress upon, that like, hey, look, it's not normal, but it doesn't mean you just have to live with it. And then like, it's almost like there's that conversation that gets to start right away with like, it's not normal postpartum, but there's also, it's not
Mhm.
normal fertility. It's normal enough
Yes.
based on the medication, but it doesn't mean you have to suffer through it or just kind of be in it. We can actually
Yeah.
do things. I think that's a big thing that
Yeah.
not a lot of people recognize. And my one gal yesterday, she just said to me, and she's 8 months postpartum with her babe, and her partner went through years of IVF. And she said, I just got my first period in 2 years. And she didn't know what that was going to feel like or
Oh
look
my
like.
gosh.
And
Oh
it
my
was like
gosh.
talking all about those things again. And she's like, yeah, I went
Mhm.
to put a dress on and I was so bloated. And she didn't even think that like
Yeah.
that was a physical cue that like her menses was starting. So it's helping people reconnect in that too.
Exactly. And you said something so crucial about people not being in their bodies enough. I think that
Mm,
is part of the work that I have to do, is kind of help people come back into
yes.
their bodies and be more aware, right? So you've got these upregulated folks who are super, super high alert. Their sympathetic nervous system is high up, they've got
Mm,
central sensitization. If they, if you touch them, they're ticklish, but then the ticklish
mhm.
turns into pain. So you've got those folks, and then you've got folks that are on the other spectrum that sometimes deal with anorgasmia, right? Or diminished sensation, right? And so
Yeah.
no matter where they're on the spectrum, thank God as pelvic floor therapists, we're equipped to handle that neurological, input. But sometimes I'm having to say, well, we need to address this. Like, we need to really make sure that this is much as part of your fertility journey as anything else,
Yes.
because there is nothing worse than not being able to be connected in your body and understand hormonally what's happening, understand what it means when you're feeling lethargy and you're not, especially folks that are taking fertility medications, you're not even understanding the impact of that medication on your body and how you're
Right.
receiving it, right? You could be having an adverse reaction and not be able to communicate that to your provider.
Right.
How many times, I remember I had a patient who they had a failed cycle, and they came to see me after the failed cycle. So I asked her, hey, could you give me a copy of the protocol you use? And I'm looking at the protocol, and it was very modest. Like, the follicular stimulating hormones were so modest. And, the first question I asked, because looking at her body size, looking at some of the challenges she's had, I was like, why were you on such a low dose stimulation?
Mm,
And she's like, oh, I don't know. I think my specialist was just like, this is kind of what they start most of their patients on. This is what everyone, responds to. And I'm like, well, if your BMI is 50 and above, and they took you, or, your BMI is 50 and you're on a low dose stimulation and you don't have regular cycles, did
right.
you not? I was going to ask her, I said, did you feel the stimulation? Did you feel bloated? Did you feel
Mhm.
cramping, discomfort during the retrieve or after the transfer? She's like, no, I don't remember feeling that. I'm like, baby girl, at that
Right.
point, you should have told your provider, I'm not sure if I'm getting stimulated enough, right? Or
Mhm.
you're
Such a
going
good
in and
point.
you're only seeing just a few follicles maturing, and they're like, okay, well, at least all we can do is one, but you don't have diminished ovarian reserve. You're younger.
Right.
Advocate for yourself, speak up. And it's not to say that, I'll like, I've met some amazing reproductive endocrinologists that they're like on it, right? But the honest truth is most folks are, I've seen quite a few on the conservative side too, right? And if
Mhm.
if you're investing your life savings sometimes into this process, speak up, right? So some of that
Mhm.
too is that equipping, and then also educating pelvic floor therapists, like you said, to use the appropriate language around their patients so they can say, oh, they never said that to me. Let me
Right.
look that up, or let me communicate that to my provider, because I never even knew that I was supposed to be asking about that, right? So yeah, it's definitely remarkable, especially when we're talking about the fertility treatments.
Right. And I always say it's like getting on a hamster wheel sometimes at certain
Yeah.
fertility
Yeah.
practices. You're just like, all right, we're running the wheel and we do this day 3, we do this
Yeah.
day 12, we do
Yeah.
this. You go through the whole gamut and you do get caught up in, well, they're telling me to do X, Y, and Z. And if it didn't work, we're going to do it again. And I think that's one of the biggest emotional triggers and frustrating things for many people, that like you're on this hamster wheel, but you're not seeing any outcome, or you're not feeling anything, or no one's listening to what you are feeling and taking all of that into consideration.
Do you know what it is, Dr. Amanda? Just something that came to mind when you said it. The real reason is, especially in Western culture, what we do and what we see, especially in the fertility world in the West, is that we are taking on the fertility process. So what's happening is patients feel like, I'm paying you to fix me.
Yes.
So there's that nuance of being disengaged from the process, right? And feeling like, as long as I'm putting these meds inside of me and doing exactly what they say, I'm going to get the outcome, right? And so there's not this involvement of like, what do I actually need to do? And what do I need to know, right? To appropriately respond. And this is part of what we're doing as rehab providers, is communicating. I mean, how many times, thinking even of our ortho folks, that someone has a total knee replacement or has like, another orthopedic condition, and they've got a protocol, but there are other things that we recommend they do along the way.
Exactly.
Exactly. Like better lifestyle changes. Hey, when you're getting in and out of your truck, this is what you need to do to transfer appropriately, right? Hey, maybe you need to modify the height of your bed so that you're not exacerbating this ligament. We do things all the time in rehab to communicate what they need to be doing. And so most patients who get major orthopedic surgery still know that they have a significant amount of work to do themselves in order to get the best outcome, because a surgeon is only going to give you that metal piece to be able to, get you that new. They're not going to help you do all the rehab, right? So that's part of too, is like changing that conditioning, that mental conditioning. And this is just a pelvic health spiel now, right? When it comes to pelvic health, is like changing that conditioning where it's like, I know that this vaginal estrogen cream that your provider is giving you is supposed to be the end all be all, and the thing that helps to improve your vaginal dryness. But here are some other things that we're going to do to address some of the pain you're having with intercourse, right? And so, and putting that gamut back into their hands, and then also that makes them feel empowered, right?
Exactly.
It gives a personal sense of strength. It gives worth to the process when someone knows that I am as involved and I can be as involved. I know that if I can tweak certain things in my diet, not only will this give me a better outcome, but this will make me feel better in my body and feel more empowered about this process. Yeah.
So true.
Yeah. Well,
so
even just helping people prepare for that, right? Because, a lot of people think like trying to conceive, like it starts once you start trying to conceive. And it's like, no, what you've been doing for years prior to that can affect your success rate with conceiving naturally, and then, even going through a fertility journey. So I think just educating people on lifestyle factors and modifications that can be contributing to that sort of thing. And the hard part is with a lot of people, it's like, you don't know until you start trying. So even, people who might be seeing us who are in their young 20s, not even thinking about conceiving, but they're at this point in their life, but eventually want to start a family, and they're saying these things, and being able to kind of address and say, like, look, if this is eventually where you want to be going, like these factors, it's not going to be working in your favor or serving you for that purpose too. So I think that's where we changed a lot of our, with our initial evaluations, even what our intake form questions are, and the conversations that we're having around asking about people's menstrual cycle histories, and
even if they're 65.
Doing a lot more, spending a lot more time talking to people, so you can really kind of get like a whole kind of picture of what this person is coming in for, and recognizing that, even if they're just a 25-year-old female who's having bladder leakage when she's like doing her HIIT workouts. But we ask about menstrual history, and then we start to uncover all these other things.
And I think the great part about that too is for somebody who isn't quite in that journey yet, or maybe has even been past that journey. I know you do a good job of it with like the younger gals that you've been seeing too, is that we can start to refer to the right people. Like there's been many a times that like they're not thinking that yet, but oh, maybe you do need to go see this pelvic pain specialist, or it might be somebody to go see now, like go see a fertility doctor now, because you might have PCOS, or do you have fibroids that have always been there, but no one ever addressed them? And maybe we need to talk about what that looks like with functional medicine nurse practitioner, and go see the endocrinologist and your gynecologist. So it's really been interesting to be in this role as pelvic therapist
or just resources for people who are curious. Like I have clients who, again, they're like, okay, in the next 2-3 years, I want to conceive, and I want to make sure that I am setting myself up. Like, what can I be doing? Who can I be talking to? What resources are out there for these people too, even prior to, leading up to,
it's like, I love those clients, the pelvic health clients that are like, so I keep hearing about this thing called pelvic health. I just want to know if everything's good going on down there. They're like the best ones. And you're like, you see them once or twice and they're like, I have a lot. This is amazing. And like, then they're much more empowered.
Yeah.
Like,
they're getting almost like a personal anatomy lesson, because they just never, definitely. I did want to touch on something, and I was thinking about, as you guys are talking about kind of empowering patients, is also partner involvement. That's a big piece, that I think folks need to really kind of know from the beginning. Is I think we do a big disservice to patients when we don't communicate how much we need the partners to be alongside this journey, right? Like I ethically don't even treat if there's not a clear indication that the partner sperm has been checked and everything checks out, And I tried to tell patients that clearly, like, hey, this is why we need to know, because we could do all this work, and if there's, poor sperm motility, if there's morphology issues, it can be a very frustrating process for you to go through. And sometimes that's difficult for patients to receive, right?
Right.
Because maybe there's a lot of shame associated with that. Or if they come from a background where gender roles are viewed differently, they don't feel empowered to communicate that to their partner or to their spouse. And so it takes a while. Like sometimes they'll say, well, can you at least start the process? I think I'm going to just need a little bit of time to get my husband on board, to be able to check things out. He just, and I'm thinking about this patient that I treated. I don't have many patients that I don't mean this to say, I say this very lightly because I don't want people to get the wrong idea. It's not like everyone gets pregnant under our care, because that's just life, right? But people are usually successful. Sometimes it happens quicker and sometimes it takes a while. But there's probably been like 2 people in my career so far that I think of often, of folks that I felt like, had we done certain things differently, I probably would have been able to help them, right? So this particular patient was advanced maternal age, several surgeries, cancer. I mean, she's had a lot going on. Had married a little bit later in her life, but at this point, they'd probably been trying for roughly 17 years. And so she, we did all this work to work through the scar tissue. When I had asked her about partner, he's good. He gets his sperm checked out. Everything's fine. Good. So we're working. I mean, she might have been at her 7th session, and I usually have this gut instinct with my patients whenever I feel like something is, and you know what I'm talking about, y'all know, like when it just something's off. And I had to ask her one day, I was like, no disrespect, but is your husband really good? Like, is he okay? And she just starts weeping. And she's like, I don't know really how to talk about this. She puts her head down, so I know there's some shame. But he's got a porn addiction. He's got like really bad testosterone, low testosterone, and he just won't do anything about it. Well, ding, ding, ding. And I looked at her and I go, well, you realize that, especially him being a couple years older than you, him not having good testosterone, him not having a good relationship with intercourse, because it sounded like he's also got some erectile dysfunction going on. He's got performance anxiety when you're during your ovulation window. like, this is crucial. And, I had to ask her, I was like, what made you feel like you weren't ready to share that? And she said, honestly, I felt like if I could do a lot, I could encourage him to take some of those steps. Like, I feel like if he saw me doing this, he would feel encouraged, and he just hasn't. I'm frustrated, right? And so I equipped her with great resources, because we have a male fertility specialist that we can call on and everything. And, I think he wouldn't go. He just said no, he didn't feel comfortable, and she just never came back. And, those are those kind of patients that you don't hear people talk about, but it just makes me realize how complicated this thing can really be, because we get in people's business all the time, right? We get in their sex life, we get in their bladder health, their bowel health. But when it comes to fertility, you're talking about people's religious perspectives, their thoughts about manhood, relationships, their view of society, their view of their bodies. It's so deep. So I never undercut how important it is for us to make sure that we're respecting people's time and what they need. And like, sometimes I tell people, like, if you're ready to get started, we can. Do you want to maybe wait? Let's get you, so you and your husband are on the same page before getting started. And they're almost usually surprised when I say that. And usually when I say that, it empowers them to go back and say, you're the reason why we're not going to start yet. Can we get on the same page? And then next appointment, he's in there with her. It's like, okay, can you explain to me what's really going on? And then we're able to work.
No, it's incredible. I mean, the work that you do, and that you're encouraging the rest of the pelvic health community to do, is unreal. Like, there are certain women I have my like goddesses that I'm always like, oh my gosh, like, they're incredible, that I look up to. And I'm sure you have your list too.
Pretty similar.
Exactly. But you're one of them too. But so it's one of those things that it's like, wow, like, we are stepping out and doing something greater than what you learn in PF1, whether that's at Herman and Wallace or APTA. And I think that being encouraged to see other people step out and do things differently is what we need to move our entire profession as physical therapists forward, but also to move pelvic health and women's health and empowerment of gender roles and different things forward. So it's really fascinating. And I'm just so grateful for people like you who are igniting all of us. So thank you.
No problem.
I want to be respectful of your time.
No, you're good. You're good. You're good. Thank you all so much for having me. As you can see, I could talk all day. So
I know. Part two.
Right. I know. We always are saying that.
We always say that with a lot of people.
So I know you're not in Jersey, but you do provide virtual consults. And you're on Instagram as well. So if people are wanting to kind of work with you or even learn from you, follow you on Instagram, how can our listeners find you?
Yeah, so the best way to find us is to visit our website, triggeredpt.com. You can always fill out a little form there to book, or you can just email info@triggeredpt.com to say, hey, I want to work with Dr. Yeni. I don't live in Texas. And our front desk is amazing. We'll definitely make sure that she communicates my availability as soon as possible. So I love working with folks virtually. And then follow us on Instagram @triggeredpt. We have fun on there. So we love
doing some amazing things. We can see the growth.
Thank you so much. So feel free to reach out to us on those platforms, and it'd be an honor to work with you wherever you're at in your journey.
Thank you.